Hi, everyone. I'm Ashley Bassett,
And I'm Catherine Logan.
and welcome to another episode of Game Plan. As you may remember from our first episode, these Game Plan episodes are specifically designed for our patients. We hope to answer some of the questions that you have about the most common sports medicine conditions, injuries, and surgeries that are available. Our last episode focused on ACL graft choice, and we're going to continue on with that same topic today, our favorite topic. But today we're going to talk about risk factors for ACL tears, some modifiable and some non-modifiable, and ways we can decrease that risk.
Okay, so please note that this episode is going to focus strictly on ACL reconstruction. For more information on ACL rehab, check out our recent two-part episode that was done with Candace Townley Cox. So she's at Evolution Physio Pro in Denver. We did that in April of this year. We also covered the addition of LAT, which is lateral extra-articular tenodesis with ACL reconstruction. We did that in an overtime episode in November of 2021. And again with Dr. Brian Waterman live at AAOS meeting in March of 2023. So, and of course, our first game plan episode was on how to choose your graft. So definitely check that one out too.
So before we dive into risk factors for ACL, we want to talk about a little bit about what the ACL is. So the ACL, which stands for anterior cruciate ligament, it runs diagonally in the knee, in the center of the knee, and it attaches the femur or the thigh bone to the tibia or the shin bone. And the ACL has two primary roles. One, it prevents the tibia or shin bone from sliding anteriorly or forward, and it also provides some rotational stability to the knee. And those two functions really are critical to allow patients to continue participating in cutting and pivoting sports.
So in participating in sports that required rapid acceleration, deceleration, and those sudden movement change, that itself is a risk factor for ACL tears. But there are many other risk factors for us to discuss today, some of which are modifiable, and you can do that through ACL prevention programs. We'll chat more about that later. And others are unfortunately just non-modifiable. So we're going to break all those down together.
Awesome. So let's start with the discussion of the non-modifiable risk factors. I think they can be grouped kind of into anatomic, genetic, and hormonal. So let's start with anatomic. So Q angle.
Yeah.
What is the Q angle, right? So Catherine, do you want to start off with that one?
So Q angle, we'll put a picture up on the video, but the way I always describe it to my patients is that the way people are built, sometimes there's a bigger angle coming down from essentially where the front of your hip is down towards your knee. So like specifically, it's the angle between, if you draw a line down from your ASIS, which is basically that bump prominence on the front, which everybody calls their hip, but is not their hip, to the center of your kneecap, and a line drawn from the center of your kneecap to your tibial tubercle. And so we know that there's like normal numbers, but it's also shown to be that it's 2.7 to 5.8 greater in females than it is at males when you're in that standing position. So a larger Q angle puts us at higher risk for ACL tears. And so the thing is, we think is when there's a higher Q angle, you're placing that ACL in a position where it's more prone to risk of rupture. So do you explain that? How do you explain Q angle to your patients?
Exactly as you just said, I explained that I kind of joke, women, we have those wider hips. So
Yeah.
with wider hips, they're going to have a larger Q angle. And I think that larger Q angle sets patients up for a whole host of issues, right? Not only ACL, but I see a lot of patellofemoral pain, as I'm sure you do. And that has to do with that lateral pull of the quadriceps kind of pulling that kneecap laterally. And it also does predispose to ACL tear. So I tell my patients that it's not just females, but it tends to be a lot of females that have this. And unfortunately, I tell them this is not something that they can modify. This is something that they are born with.
Yeah. So, and we'll talk about this at another time, but that Q angle, we can't modify it, but there's some other things that we can do with those prevention programs to say, I think the other thing that results with that Q angle is when we work out our legs, we tend to be very laterally dominant. So how do we also build up the other aspects of our thigh?
Exactly.
So then anatomically, Ashley, there's other stuff like inside the knee joint.
Yeah.
So if you want to speak a little bit about what are the things anatomically inside the knee that affect ACL risk?
Yeah, absolutely. So this conversation always kind of circles around our female athletes, right? But it is important to note that these factors don't just impact our females. So one is a narrow notch. So Catherine, I'm sure we'll put up a nice diagram showing this, but there's essentially three main types of notches. There's the A-type notch, which until there's a diagram, I'm just going to demonstrate it, which looks like this. There's the U-shape. Is that good for everyone? There's the U-shaped notch, which looks like this. And then there's a W notch, which has a little bit of an apex kind of in the center. And studies have shown that that narrow A-shaped notch, it kind of makes sense, right? It's a narrower space for the ACL to live, and it leads to some impingement on the ACL. And they have shown, there was a study, it's an old study from 1994, showing that Division I athletes that had that narrow A-shaped notch were at a higher risk of sustaining an ACL tear. And there's been a boatload of studies that have showed that females are more likely to have that narrow A-shaped notch than the wider U-shaped notch. Males are more likely to have that. So that's one. And then smaller ACLs, which kind of makes sense, right? I mean, as females, we have smaller bones, we have smaller muscles. We're also going to have smaller diameter ACLs. They've shown the mid-substance diameter is smaller in females compared to males. But if you're a male with a smaller diameter ACL, you are thought to be at a higher risk. What do you tell your patients about this? Like maybe starting with the notch. Do you address that with your patients?
I can't say I focus like too much on, hey, we got to think a lot about your notch, but I do talk about diameter. Like in my discussion of which graft to choose, this comes up all the time because we know that having a smaller diameter graft makes the failure of the graft higher. And then similarly, if we have a smaller ACL diameter, you're more at risk for actually tearing in the first place. So I do definitely discuss diameter. And then, just on a whole, like when they're coming in and they've had an ACL tear or they're nervous that, they're at risk for one, it's part of a bigger conversation of like, look, there's things you can change and there's things you can't change. It's important to understand that there are things you can't change, just so you don't feel like if there is an injury, gosh, should I do something wrong? Some of it is part of just, the reality of how we're built, genetics and the hormones. And then lastly, we didn't talk about yet, posterior tibial slope. So this is something I definitely don't really speak a lot with my patient because I think it can be a little bit, we're obviously including graphics up here to describe what we're talking about, but increased posterior tibial slope, or basically the way our tibia bone kind of is shaped, it also changes the risk. And that was, that can be addressed as far as how the ACL is reconstructed. Do we want to also change the slope of the tibia? But I also feel like that's a huge deal to do. And most people are not really adding that into regular practice. What about you, Ash?
No, I agree. I mean, I think it's something, I don't know about you, but I'm looking at it more in a revision setting, when we're working up why an ACL failed and we're ruling out infection and we're ruling out malposition tunnels or ligament laxity. I'm also measuring the posterior tibial slope to see if it's that high number. I believe Leprod quotes that greater than 12 degrees to see if they would need an osteotomy. But I mean, as you perfectly put, it's a major procedure to add. I mean, if you have to, just like adding an HTO to a revision ACL to correct, varus malalignment, which for our listeners is basically bow-leggedness, which can increase the risk of having an ACL graft tear. You could add an osteotomy to address increased posterior tibial slope, but I just don't think I'm really focusing a lot on that in the first time I'm meeting someone with an ACL injury.
Yeah, so I think that sort of wraps up really the anatomic risk factors. Did I forget any?
No, I think that's perfect.
So let's move into genetics. I recently had this conversation. We've talked before on the podcast about my sister. And so my sister had 3 ACL tears, same knee. And then I've also talked on the podcast before that one of her daughters also had an ACL tear. And then sad news update, her other daughter also had ACL tear. So let's talk genetics. So why have all of them torn their ACL? And knock on wood, if I had wood near me, I have not. So that brings us to genes. So what about call 5A1? Do we remember that back from med school?
It's somewhere deep in there for deep. Boards, measured with all the translocations with the different with the different conditions. So yeah, I think, it's funny. I don't know about you think this, Catherine. Things we learn for exams and like memorize oftentimes don't end up being clinically applicable.
Totally.
And I think this is kind of one of them. I think it's really interesting, especially in the setting you bring up with your sister and your two nieces having this. But I think it's been shown to be somewhat of a high risk factor. So for our people who are listening, essentially, there's a variety of types of collagen, one all the way to, I believe, 13. And this gene modification in a type 5 collagen has been shown to lead to disorganized collagen fibrils, which is essentially what makes up the collagen. And because it's disorganized, it's weaker, and they think it leads to ACL tears. Interestingly, this only occurs in females, this underrepresented kind of genotype or this gene disorder, hence your nieces, but doesn't occur in males. So it's really interesting, but I think it's not as potentially as a big of a deal as it was on our exams, but it is something interesting to think about, for the future. Where can we go from there with, gene modification and things like that? What do you think?
Yeah, same. I don't even know, to be honest, like how expensive that testing is. And, even if like you go and you did genetic testing and you find out, yep, this is consistent with my makeup, like, what are you going to do about it? You're not going to say, I'm not going to play basketball anymore, or any of the sort of the high risk sports. You're going to live your life and sort of wait and see how it goes. So I think, interesting. It's sort of like a fun fact, but there's nothing you can do about it. And then genetically, I think that's really the only things that, that we know about. I'm sure they're working on something that we don't even know about in the lab.
And then we'll give an update. Awesome.
So let's move on to hormones.
Yeah. So what do you tell your patients about this? I'm so curious to hear what you have to say, because I think depending on what you read, there's some things that say it does have an effect, and then some things that say, nah, just in animal studies. So what kind of conversations do you have with your female athletes that come in and they're all worried about, their menstrual cycle and how that may affect when they should be playing sports? What do you think?
Yeah. I think it's like, we know that there's some data that shows when girls are ovulating that they have a higher risk for an ACL tear. Do we always know when we're ovulating? No, and then, the other thing with menstruation, I don't know what about your clinic, but I find that most young, female athletes are doing IUDs now, as far as for their birth control. So they're not even menstruating anyway, or for the most part, they're not. So they don't even always know when their cycle is hitting. So it's a very, so if I'm even trying to take that data in my clinic and understand, did this happen at what part of your cycle? And a lot of times they're like, I have no idea, so I think, like you're saying, it's all in animal studies that we know that estrogen and relaxin are part of the factors that we cannot modify per se. But what are we really going to do about that? Do we know that sort of data live? And would that mean that, okay, we're not going to, play this weekend because I'm ovulating? No,
Yeah.
So I don't, again, I think kind of like the genetics, what are you going to do about it? But yes, it just helps. I think the way I think about it is it helps that girl understand that, she didn't do anything wrong. There's a lot of risk factors there. It's not because you weren't strong. It's not because you didn't have good technique. Sometimes that's the problem, but I think there's a lot of factors. What about you? Do you share it any differently than I do?
No, kind of exactly what you said. I basically just let them know that this is yet another downside of being a female athlete, that this is another thing that puts you at increased risk. In addition to the ligament laxity, in addition to the higher Q angle, this may put you at a slightly higher risk. I think it's really important to point out, because people can feel really defeated when you say that a lot of studies have shown that you really need super high levels of estrogen in order to have an impact on the ACL laxity. Everyone focuses on the receptors in the ACL, that you really have to have super high levels, which I don't think most people are having. It increases your risk, but it's not tremendous. Our males also have circulating estrogen as well too. The relaxin is really interesting. That Dragoo study, which we will put up a picture of, showed that basically athletes that had higher than 6, I believe it was nanomoles, nanograms, don't quote me on that, higher than 6, were at a higher risk of having an ACL tear, and that was really significant. So, could there be, something, in the future down the line, ways to decrease the relaxin kind of concentration, because that's something that we only see in females, right? Males don't produce relaxin, they don't have receptors for relaxin, and so that is something that's really unique to them. But again, I'm mostly having that conversation with them from an educational perspective. I'm not really saying let me go put you on a relaxin blocker that doesn't even exist. I wish. But it's just more conversation to have with people.
Yeah, no, I think that's a good way to put it.
Awesome.
So,
And
do you
then
want to talk environmental? I totally interrupted you. Go ahead, Ashley.
no, it's okay. No, that I was just going to say the same thing, which, I think we briefly talk about this. I don't know
Yeah.
about you. Do you feel like anytime there's an ACL tear, heaven forbid it happens on a turf field because everyone's coming in. It was the turf field. It was the turf field. What are you telling your parents and your athletes about the risks of turf? Is it just turf, or is it turf and shoes, cleat type? Do you think it's a combination of things?
I also think I remember when we were talking to James Woos, so from
Yes.
the NFL, he what they were sort of talking about as far as their injury rate, not just ACLs, but injuries on turf was like there's also different quality of turf, and I think there's
Hmm.
also different quality of grass. So I think we try and oversimplify, oh my gosh, turf versus grass, and one is evil and one is perfect, whereas I think there's a lot of variability with both, and so there's good turf, there's bad turf, it's what's well maintained. And I know you'll see lots of studies where they find no difference, so I don't get too
Hmm.
hyper intense, I would say, about playing surface. But I do think a bad playing surface and like a basically one that's not well maintained is going to be a risk anyway.
I completely agree. Yeah, it's really important. You pointed that out, and James brought that up too when we were talking about that. That I think there were two teams that they were
Mhm.
instructed by the NFL Players Association to redo their fields
Yeah.
because they were such old first generation turf fields. They were putting athletes at risk of having injuries. But I think once you get to second generation, third generation, I think it really boils down to shoe wear. We talk about good fitting cleats. We talked about that beast
Oh yeah,
model
the
to
tester.
test.
Yeah.
Yeah, we talked about that in that episode too, where basically they're testing the traction between cleats and the ground. And you would think you want this cleat that really has good traction with the ground, but you actually don't want as much
Yeah.
friction between the foot and the ground. You want the foot to be able to be released. And something interesting I found when I was kind of doing some prep for this episode is that they've actually associated weather with ACL tears,
Yeah.
that if it's
I had no
hot,
idea.
yeah, hot and dry. So
Yeah.
there's essentially lower friction between the foot or the cleat and the ground. It doesn't release as well. And so you
Yeah.
want to play counterintuitively. I would think like wet, slippery
Yeah.
fields would be worse. You want to play on wetter, less evaporated fields because it provides less traction, which is interesting. So, as you said, I think a lot of factors go into it. And I think it's a conversation to have, but I usually try to reassure parents that it's not just the field, it's
Right.
not just the cleat, it's not just the
Yeah.
female athlete, it's a combination, wrong place, wrong time factors that led us to here.
I also think, like, similar to how we're always trying to take these different data points on intake when someone already comes in with an
Hmm.
ACL tear, it makes me want to like ask about the weather.
Yes, I know.
Just for those field players and just like, I don't know, kind of see what we come
Well,
up with.
well, fun fact, my PA will
Yeah.
love that I shared this story. So she tore her ACL when she was a high school athlete. And I told her this when I was reading this, and she goes, huh, I tore my ACL on a rainy day. My foot slipped and my knee went the other way. And I was like, oh, I mean, I don't know. That's what I would have thought too, but that's not what the data says. So
Yeah.
yeah, I think it's going to surprise a lot of people, but there are a couple studies out there on this. And interestingly, they do show this. So.
Yeah. Perfect. So why don't we talk about things we can change and be like
Mhm.
a little bit more positive?
Yes,
Because everything's so
exactly.
hard, and like things you cannot change.
Hmm.
We've talked about this a bunch on different episodes, but core strength.
Hmm.
So anytime we're talking about ACLs, I talk to patients a lot about it. As we get into the later stages, I start asking them, what are you doing for your core? Are you doing Pilates tenant based workouts? Because those are things you can do very early that you're going to work on a lot of that proximal strength. But
Hmm.
we know that the data shows that good core strength is going to improve your muscle activation patterns, your joint kinematics, and help reverse the things that make us more predisposed to ACL injury. And I
Hmm.
think you've said the same thing. You now incorporate core strengthening, or I should say like core testing in your return to play. Is that right?
Yeah, that is true. I think it's really important. I think it all goes to that the kinematic chain. Everything is connected, and it all starts with the trunk. And we know that specifically in like our baseball pitchers, that
Right.
that it all comes from the trunk. But can you share? Because I remember we talked about
Yeah.
there was an article from AJSM. We talked about it with Mary, I believe it was, on like the impact of core on decreasing the risk of ACL, and you shared a core test that you do in clinic that's very difficult for patients. Can you share that and maybe like include a picture of it? Because I found it really interesting.
I'll include, I think I have video. I'll try.
Oh, that's awesome.
But yeah, so I will layer that in. But basically, it's easy to do in clinic. I have people do it on the treatment table, lying on their side. So their body's not in a totally stacked straight line. Their hips are sort of flexed about 30 degrees forward. And then I have them raise their top leg and then have their bottom leg try and reach it. So, and then the big trick that you'll see like in the graphic is that the whole upper body has to be really quiet and still. So the tendency, if your core is not helping you, is like you like grip the table really hard and like try and use your upper body to stabilize. But people, it's almost like a positive or a negative test. Like you can either do it or you can't. And so that's the test that I use very easily in clinic. And you can see that like if someone who is a young person who's recovering from ACL and cannot do that, they're so like, what is going on? Like I'm clearly not activating my core at all. Anyway, that's my like simple test that I add in there.
That's awesome. And I like that it's easy to do in clinic. It's something you can show patients because we're a little bit off tangent here, but I think the biggest thing is patients feel ready oftentimes before they are after an ACL surgery. And when you show them these things, when you show them that, like the first time they can't straight leg raise at first, they're like, wow, I'm not there. But this kind of shows them that they may feel like they're ready, but their core stability is not there. The rest won't follow, So I think it's really important.
Totally. And the other way I explain it to people is like, if you don't have good proximal strength in your core or your hips or your glutes, and we'll talk a little bit more about hips next, it's going to translate down. And those are the same people that end up, their knee moves into valgus, like their knee drops in towards the midline when they're trying to do single leg squats, or even just like simple things. They're trying to like lower down the stairs. Like if you don't have those engaged, it's just going to fall to the knee and you're going to have some faulty mechanics.
Absolutely. Yeah. So you hit some really important points that I think we should dive into. And there's an illustration that you probably also have. It's from a Yellow Journal article looking at ACL risk factors, and it shows the position of no return on one side and then what it should look like on the other side. And you kind of hit a lot of those points, right? Like hip internal rotation, meaning the foot is pointing inward, and adduction, meaning the hips brought in, and then, knee, the, medial hamstrings being weaker than the lateral hamstrings, and then the foot basically arch being flat, right? All of that leads to what you were saying, which is that dynamic knee valgus, which puts a tremendous amount of strain on the ACL. So, I think we talk about that. Maybe let's start with the hip. Like, how are you having patients? You were a physical therapist for 7 years before you went into orthopedics. So how are you having patients strengthen up, maybe starting with their hip to kind of decrease their risk of falling into that pattern?
So a lot of it is strengthening like your hip abductors. So all of your, sort of your glute muscles, and working on not only a little hip extension, but also external rotation. So the easy thing I give people is really like a standing fire hydrant. So we'll include that graphic, but it's basically you're standing on one leg. It's got the leg you're standing on has a soft knee bend just so you're not locked out. And then you're kind of doing that sort of hydrant move, and like it's like based on a dog peeing on a hydrant, like that sort of movement. So it's just opening up your hip.
I'll include that graphic as well too for people.
But the way that I tell people to do it, and it's kind of silly, like, is that I tell them to do it when they're brushing their teeth. So I'll say like, normally that looks really good.
It does look really good.
Brushing your teeth the way you should for 2 minutes. That's a good way to do it. You can just sit there. I mean, you're not doing anything. It also gives you like a little perturbation, so it makes it a little harder working on your balance. And like bonus points, keep a little band in your bathroom and throw it up there. But so that's generally when I tell the patients to do it, and I feel like it's super, super easy to fit in.
Yeah.
And then we've kind of mentioned it a few times, Ashley, the quad. And having some dominances, sometimes being more laterally dominant, or maybe just being quad dominant in general. What do you think about those things?
Yeah, so I think of it as like a two-part problem. So there's, as you put it, quad dominance just in general. That, and again, I hate to point everything to female athletes, but females tend to have higher quad to hamstring activation ratio, and ideally you want those to be co-contractions. You want those to be together because a quad overpowering the hamstring pulls that tibia, that shin bone forward, which would make sense, it stresses the ACL. And the highest stress on the ACL has been shown in people that land with their knee almost in full extension, so that quad dominance and slight internal rotation. So you want to try to avoid that position. But then when you break it down, it's not just the quad as a whole, it's the lateral quad overpowering the medial quad. Yeah. And again, we see that in a lot of our issues, with Q angle, like we talked about at the beginning, but in patellofemoral pain, that rectus and that vastus lateralis overpowering the vastus medialis oblique and pulling that kneecap out laterally. And that same imbalance is going to lead to that dynamic knee valgus. So that's where I'm really hammering home the VMO activation that people can do. Simplest one I have people do until they can get into PT and learn more, learn better ones, essentially just to externally rotate the foot and do straight leg raises with that, apply a weight and do it that way. And that really does engage that VMO. And so I think that's really important. I think it all matters, but I think that may be arguably the most important part of modifying the faulty biomechanics to lower the risk of injury. What do you think?
Yeah, I do. I think the way I sort of describe it, at least to the female athletes, I'll sort of like point out, when you look at like an athletic guy's leg, they generally have much more development of that teardrop muscle, that VMO. So is your leg going to look like that? No, but we can do a better job of winning that tug of war with our kneecap pulling more laterally than it is, medially. And then I think the other thing that really helps us not be so laterally dominant in the quad is really having that hip activation, that glute activation. So I think the two of those together, those are the things that we can do the most just to modify and sort of take control of that dynamic valgus. And this is like one of the areas that we can say, yep, we can change this, we can do better, and that we're not sort of destined for like these ACL injuries.
Exactly.
And the foot and ankle stuff we haven't touched on yet. And I think that one is harder for me to like kind of wrap my head around. It's harder to like see in the clinic, and it's harder to test. I don't know if you have a good way of testing it like in the clinic space. I think it's just a little bit harder to tease out. Whereas like if you're looking at someone do a single leg squat, knee valgus is so obvious. So I don't know if you have any tips and tricks for, more distal.
Yeah, so I'm primarily I'm having them walk barefoot in my clinic, and I'm just looking at looking for that too many toes sign where I'm standing behind them, and I'm looking to see if they have too many toes laterally that shouldn't be there, looking to see if I can see their big toe, kind of looking straight ahead, looking at their heel and seeing if there is that essentially valgus malalignment of their heel, kind of all the things we learned in foot and ankle. I think those identify like the biggest, the concerning ones, right? The ones that really have pes planus, which for our listeners is flat foot, that can be addressed with orthotics or posterior tibialis tendon strengthening, which we will include a graphic here. That essentially is the tendon that supports your arch to prevent the foot from collapsing flat. And so those ones you can pick up on. Dynamically, like I think what you're getting at, I don't really have a good test for that. I really rely on our PTs just to kind of pick up on that. So if it's like more fatigue causing eventual arch collapse that is leading to that valgus, I don't know if we can pick up on that in clinic. I think that's something that may get picked up on like in the PT setting where they're really putting them through a 90-minute evaluation and then seeing what they look like.
Yeah, I think you're right. I think that probably needs a little bit more teasing out.
Yeah, absolutely. Awesome.
So,
well, I think, so that's a downer, guys. Like all those risk factors, but stay tuned because we're gonna do an episode on how to stop those, right? How to address those, Catherine. I think that's coming down the pike. Ways to kind of lower at least those modifiable risk factors to try to decrease the risk of injury.
Yeah, I think we kind of gave you like a 40,000 foot view of what are the things that you can modify. And then our next game time that we're going to plan for you guys is really focusing on, okay, how do you actually do those things? Like, yes, you told me the big bullet points and we've included a lot today, but a little deeper dive into all the ACL prevention programs because there's a lot. And just trying to figure out what's good, what's not good, and are they all good?
Yeah. Exactly. Yeah, there's so much out there, It's we'll give you a sneak peek. You can't just do it once. You got to do it more than once, which is the first lesson I teach people. But I'm really looking forward to that. I want to hear what you do, and I'm sure hear what I do, and hopefully we can come up with a plan that really is ideal to kind of spread around our community. So looking forward to that.
Perfect. Well, this was fun.
Awesome. So everyone, thank you so much for listening to this episode of Game Plan. We hope you enjoyed our conversation as much as we did today. We had a good time. So make sure to follow us on make sure to follow us. I'm so excited I can't speak. Make sure to follow us on Apple Podcasts, Spotify, Amazon Music, Audible, wherever you get your podcasts, and subscribe on YouTube, where hopefully you're watching us right now. So if you want to reach us for any reason, question, or a suggestion for a future episode, we'd love to hear from you. Our email is thesportsdocspod@gmail.com. You can also find us on Instagram at the Sports Docs Pod, and Twitter at the Sports Doc Pod, no S, because we're character limited. So we love your feedback. Have a great night, everyone.
Yay. Thank you.